take medication because you need to function. You need to silence the anxiety and you need to lift the depression. But you also need to feel like you again. And for your mental health, it works. But then you start to notice a different kind of silence. The desire is gone. Or maybe the desire is there, but the physical equipment just refuses to cooperate. It's the classic silent trade-off. You trade your sanity for your sexuality. I'm Dr. Anand Chaturvedi, an adult psychiatrist and clinical researcher, and I have this conversation with men in my office constantly. And the biggest tragedy is that most men suffer in silence. They think their body is broken. They think it's all in their head, and it's not. It's chemistry. Today, I'm going to walk you through exactly how the 3 most common categories of psychiatric medications can hijack your sexual system. We are going deep into the biology, serotonin, dopamine, prolactin, and nitric oxide, so you understand why this is happening. And stick with me until the end because I'm going to share the actual clinical strategies we use to fix this. Let's start with the most common culprit, the SSRIs, selective serotonin reuptake inhibitors. These are household names: Prozac, Zoloft, Lexapro, Celexa, Paxil. Statistically, a huge percentage of them experience sexual side effects. Here is the biological mechanism that most doctors don't have time to explain to you. These drugs are designed to increase serotonin in the synaptic cleft. Serotonin is the contentment chemical. It helps you feel calm, stable, and safe. But biologically, serotonin has a rivalry with another neurotransmitter, dopamine. Think of them on a seesaw. Dopamine is your drive. It represents craving, seeking, and libido. When we artificially boost serotonin to treat depression, we often inadvertently suppress dopamine signaling in specific reward circuits of the brain. You might find yourself saying, I know I should want sex, but I just don't feel the urge. That is the dopamine suppression talk. But it gets more physical than that. Some of these medications, particularly Proxetine, which is Paxil, can actually inhibit an enzyme called nitric oxide synthase. If you watched my other videos, you know that nitric oxide is the holy grail of erections. It is a gas that tells your blood vessels to open up. So if a medication is dampening your dopamine drive in the brain and potentially reducing nitric oxide in the body, you have a perfect storm for dysfunction. It can manifest as delayed ejaculation or what we call anorgasmia, when you simply cannot reach the finish line no matter how hard you try. Now let's move to category number 2, benzodiazepines, Xanax, Ativan, Valium, Klonopin. These are often prescribed for acute anxiety or panic. Mechanistically, these work on the GABA system. GABA is the primary inhibitory neurotransmitter in your brain. So in plain English, it's the brake pedal. So when you take a benzo, you're actually slamming on the brakes of your central nervous system. Now, if you are having a panic attack, that is exactly what you need. But let's look at this through the lens of performance. Sexual arousal is a complex dance between your sympathetic nervous system, or the accelerator, and your parasympathetic nervous system, or the brake. Benzodiazepines are a massive blanket of sedation over the whole system. They can dampen the limbic system, which is the emotional brain responsible for arousal. If your nervous system is too sedated, the signal simply doesn't travel from the brain to the body with enough intensity. You might feel relaxed, but you're too relaxed to perform. Furthermore, chronic use of these medications can sometimes interfere with testosterone production indirectly, though the main culprit here is usually just systemic sedation. So you're not broken, your system is just asleep. Category number 3 is where things get metabolically complex. Atypical antipsychotics and mood stabilizing drugs. Now, these medicines like risperidone, haloperidol, or olanzapine, we use these for bipolar disorder, schizophrenia, as adjuncts for severe depression, and also mood stabilization. But some of these agents have very specific side effect profiles that are devastating for men. Now, this involves a hormone called prolactin. Normal dopamine activity keeps prolactin levels low, but because many antipsychotics work by blocking dopamine receptors, the brakes come off prolactin production. Prolactin levels spike, and this condition is called hyperprolactinemia. Why does this matter for you? Prolactin is a hormone primarily associated with lactation and breastfeeding in women. In men, high prolactin is a testosterone killer. It tells your body to shut down testosterone production. And it can also cause gynecomastia, or breast tissue growth in men. And it makes erections nearly impossible. This is the hormonal hijack. It's not psychological, it's a direct endocrine side effect. Okay, that's the heavy stuff. If you're listening to this and nodding your head, if you're thinking, that is exactly what is happening to me, take a breath, because this is solvable. Here is the doctor's edge approach to managing this. Strategy number 1, the adjunct approach. If your antidepressant is killing your drive, we don't always have to stop it. Sometimes we add a counter agent. The most famous one is bupropion, or Wellbutrin. Unlike SSRIs, bupropion works on dopamine and norepinephrine. It doesn't touch serotonin much. Adding this to your regimen can sometimes wake up the sexual system and counteract the numbing effects of the SSRI. It's like adding a shot of espresso to your morning routine. Strategy number 2 is the switch. If you're on an SSRI that is causing major issues, talk to your doctor about switching to something with a lower sexual side effect profile. Medications like mirtazapine or vortioxetine work differently and often spare sexual function. Or if you're on an antipsychotic that raises prolactin like risperidone, we might switch you to a prolactin-sparing agent like aripiprazole or quetiapine. A simple swap can sometimes solve the problem entirely. Strategy number 3, timing and drug holidays. Now, I want you to hear me clearly. Never stop your medication without your doctor's supervision. Withdrawal can be dangerous. However, for some medications with short half-lives, doctors sometimes might approve a brief holiday. For example, skipping a dose on a Friday morning might allow enough washout for a normal function on Saturday night. Again, this is strictly a conversation for you and your provider, but it is a valid clinical strategy we use sometimes. Strategy number 4, treat the biology directly. If the plumbing is the issue, meaning you have desire but no erection, we can treat the plumbing. PDE5 inhibitors like Viagra or Cialis can be safe to use alongside most psychiatric medications. They don't fix the desire, which is the dopamine issue, but they fix the blood flow, which is the nitric oxide issue. So using these doesn't mean you have failed. It just means you're using a tool to bypass a side effect so you can maintain intimacy and connection with your partner. Here's the bottom line. Mental health is non-negotiable. You need a healthy mind. But sexual wellness is a huge part of being a healthy, confident man. You should not have to choose one or the other. If your current provider isn't listening to your concerns about side effects, be your own advocate. Bring these ideas to the table. Ask about switching, ask about adjuncts, ask about prolactin levels. You deserve to feel good mentally and physically. And if you found this breakdown helpful, hit that like button so YouTube shares this with other men who are suffering in silence. And make sure you subscribe to The Doctor's Edge for more science-backed deep dives into your brain and body. I'm Dr. Anand Chaturvedi. I'm going to see you in the next video.